the difference between a trauma-informed assessment versus a screening tool and how that helps us to prioritize trust, dignity, and autonomy for our patients. I want to go over why trauma-informed assessment is more effective and helps us to address some of the control tactics, talk about the PEARR tool and how you can apply it in practice, and how creating system protocols helps support patients and trust in health care systems. Before I get into the weeds with this, I just wanted to say that it's perfectly understandable that we've had situations that are not aligned with best practice. We do the best we can, as Maya Angelou said better than anyone that I we do the best we can until we know better. And when we know better, we do better. And if you've had a situation that isn't aligned with best practice, don't blame yourself, just take the knowledge that you learn and pay it forward so that we can continue to have better outcomes with our patients and make sure that we aren't making things more difficult for them. So healthcare providers are inclined to do screenings, which is perfectly understandable. It's a simple yes, no, and that's with medical care. It's helpful in pattern recognition, what the patient is dealing with so that they can get to a diagnosis or steer toward the best way to treat the patient. The difficulty is, though, with screenings is they tend to throw up all of the walls of people who are being trafficked. There are lots of reasons why these individuals don't trust healthcare systems or systems of authority. So we had recently a sting here locally that was called Operation Better Pathways, and in that there were doctors included in those that were arrested. So it's not out of the scope of possibility for healthcare providers to be contributing to the exploitation, either as buyers or traffickers. And there's a lot of other reasons why these people maybe aren't going to trust us. So we shouldn't expect that of them. What's nice about assessments is it lets patients know that we care about what's going on with them, and also offers some support in that situation without pressuring them to disclose what's going on. So that's done without manipulation, which is really important. And that is the trauma-informed approach. And we'll talk a little bit more about that too. There's an article that I referenced at the bottom of this called It Has to Be Their Choice. We need to give them options. And this is co-authored by Dr. Hani Staklosa and a survivor advocate who help us to unpack all of the nuances of the reasons and how people are coerced, and the reasons why they would mistrust healthcare providers. So some of the stress responses that kind of throw people off, we're pretty familiar with fight, flight, and freeze. And that's what typically people consider normal in a stress response. However, when someone is in an abusive situation like domestic violence or human trafficking, there's an additional chronic stress response that's sometimes called fawn because it fits the alliteration here. I've heard survivors that don't really like that terminology, but it's where the individual proactively appeases or performs the behavior that is expected of them so that they don't have backlash. And that's one of the things that can throw people off because they're expecting someone to ask for help and for it to be obvious, and it's not always that way. So some of the things that can contribute to this are adverse childhood experiences. If you're familiar with ACE scores, There's a ranking of up to 10 that includes abuse, neglect, and household challenges. Another aspect of this that's more recent is we've started adding community violence, natural disasters, bullying, refugee status, and witnessing this type of event. So if there's community dysfunction, those can also normalize trauma and make it so that it's not something that people, especially minors, push back against or that triggers alarms for them. So some of the red flags, the reason I included this in this presentation is that sometimes the red flag documents that are included are hyper-specific and say things like tattooing. The document that I've linked at the bottom here is a document that focuses instead on control tactics, things that aren't specific to a subset of trafficking, but the broader context, which includes labor trafficking and things that are outside of stereotypical sex trafficking, which would be pimps or gangs, but there's also familial trafficking or trafficking by cults or survival sex that minors do when they're vulnerable and homeless. So while tattooing and those types of things are true, if we're only looking for that, we can miss things in a broader context. So the document at the bottom is done by NTEC, and that's done in consultation with experts and survivors. And it's the one I highly recommend because it doesn't cater to bias. So trauma-informed care, I want to unpack this so that we're all on the same page. We want to create an environment that helps our patients feel physically and psychologically safe. That to them might be very different than what it is to you. So it's important to include all of the other aspects here of trauma-informed care that include trustworthiness, like if you want to hand off the patient to social work or another clinician because of your concerns, it's important to do that with transparency. You don't want to do anything that would undermine the trust that you've built. Peer support is excellent. Some of our nonprofits have access to survivors who understand these experiences and know how to relate to individuals. And we're working as a community to have paid survivor advocates so that we can be more proactive about peer support. Collaboration and mutuality, that is where you are offsetting that power differential that frequently happens in healthcare. So frequently there's an expectation that the provider, the physician knows what's best, and you're just supposed to comply because that's what's expected of you, which sometimes isn't the best approach, especially if you are dealing with someone that has trust issues. So as much as possible, you want to offset that power differential and help them to know that the healthcare is something that is happening for them and not to them. Empowerment, voice, and choice, that's where, if there's 12 correct ways to do something and the patient is comfortable with one of them or two of them, that's where you want to focus your efforts. So letting them know that what they think and feel is important, and letting them direct their experience as much as it is reasonable and safe. And then cultural, historical, and gender issues. We want to make sure that we have an attitude of cultural humility. So not all cultures, even within our country, are the same. And so if there's often, I hear cultural competence, but maybe that's not realistic, that we are familiar with all cultures and subcultures. But if we have an attitude of cultural humility, then we're open to people wanting to approach things differently or seeing them differently and helping to support their dignity. So These are the basic principles of trauma-informed care. Now, the previous slide, the 6 principles of trauma-informed care, are also included in person-centered care, which is a framework that a lot of healthcare systems use. Then the 4 R's of trauma-informed care are something that really can and should be added to that to also help the patient experience to be as positive as possible. So the first thing is that we want to realize that trauma is not rare. All of us have experienced some type of trauma on some level, whether it's fear of healthcare or adverse childhood experiences, or a violent crime or natural disaster. Trauma is cyclical trauma, and sometimes that throws people off in the healthcare setting because when they hear trauma, they think of physical trauma. So we're talking about psychological trauma. So it's important for us to recognize the signs and symptoms of trauma as we see it in patients, but also in our colleagues and in families, so that we can respond in ways that help them feel supported and safe. And with that in mind, like, we know that from our recent community health needs assessment, and I'm sure that this is not news to any of you, that we have a lot of burnout in healthcare. We have a lot of understaffing. And so the more to psychologically support our colleagues, the more we can push back against that burnout and help each other to thrive and do well. And then the third is to respond. One of the ways we can do this is to integrate trauma-informed approaches into all of our policies and procedures, things like talking patients through things before they happen, being clear about those things, setting an environment that is psychologically safe for them. And the fourth, which is probably the most important, is that we want to resist anything that would re-traumatize them. So, for example, if you find out that your patient has experienced domestic violence or human trafficking, it's understandable that they would want to discuss it with you if they feel safe. It's also perfectly natural that you would be curious. However, you definitely don't want to unpack that more than what you're professionally equipped to help them with. So you want to get enough information so that they get appropriate resources, but you don't want to get so much information that you can trigger them or create vicarious trauma in yourself. So it's important to observe that, not just for your patients, but also for yourself. So this next part is a video.
There was a lot going on for me. I just needed to take a deep breath. My mom had just been diagnosed with cancer. I was entering yet another surge of COVID. And I think this was like the 4th overnight shift in a row. I couldn't even keep track at that point. So I took a deep breath and swiped my ID, and the emergency department doors swung open, and I was greeted by that familiar chaotic cacophony of patient alarm bells ringing, ambulance sirens going off, radios crackling, a patient vomiting over there in the corner. That was a really hard shift for me. There was this moment when I saw a number of my colleagues running in a direction. And in the emergency department, we don't run unless something's really wrong. So I ran. And I'll still remember it. As I was rounding that corner, I saw that a patient was assaulting one of my colleagues. And my colleague then became my patient. And the injuries that my colleague sustained would have permanent effects on their life, I quickly learned as I was caring for them. Being an emergency medicine attending physician is really, really hard. And there's a reason why emergency clinicians across the globe are burning out left, right, and center. The good news is that I have an antidote for burnout in emergency medicine. And that antidote is trauma-informed care. Now, before you interrupt me and ask well, why would I ask busy clinicians to do something more? What I have to tell you is that I had those same questions, but the more that I've striven to integrate trauma-informed care into my practice, the more I've seen that it gives me deeper meaning in the work and brings me back to the very reasons why I chose emergency medicine in the first place. So what do I mean by trauma? As an emergency physician, I thought that when we're talking about trauma, we're talking simply about physical trauma, gunshot wounds, stabbings, motor vehicle accidents. And what I've come to learn is that trauma is so much more. Trauma is collective, like what we're all experiencing right now in terms of COVID. Also on the collective level, racism is a form of trauma. On the individual level, it's many of the things that you might think of, including assault, like my colleague experienced. So knowing this expansive definition and knowing that not just all of my patients have experienced some sort of trauma, but also many of my colleagues and staff members have experienced trauma, it's imperative, it's vital that emergency medicine take a universal precautions approach when it comes to practicing medicine and incorporate trauma-informed care into everything we do. It should really be the default mode. Now, what do I mean by what this looks like in practice? It's a framework based on 6 principles. Let me take you back to that same shift, to a patient I was caring for right after I took care of my colleague. And she was a young woman who came in with a toe infection. And she was in a curtained room. There was no door. So I announced myself before entering the room, and I asked if it'd be okay if I came in. I found a stool somewhere and was sitting at eye level with her and just asked simple questions like, how can I help you today? And immediately she told me, I have this infection in my toe. I really want antibiotics and I want to get out of here as soon as possible. And she's like, please, please, please don't tell me I need a procedure. And I asked her to tell me more about that. And she shared that the last procedure that she'd had in a hospital was a really traumatizing experience. And in fact, as she was telling me this, she started to get sweaty and she looked like she would almost pass out on me. I told her, everything is your choice and there's nothing we're going to do without your permission. Also, we have strategies that can make it a less stressful experience if you do need a procedure. And I was recommending a procedure. And so together we came up with a plan that involved doing the procedure, but she was going to distract herself on her cell phone and try some deep breathing. I was very candid if something was going to hurt during the procedure. And before I did anything, including examine her, would ask her permission at every turn. What surprises me and surprises me every time is that she thanked me as a result of that encounter. And what I've learned over time is that practicing trauma-informed care gives strength not only to my patients, but gives more strength to me. I feel like I'm healing beyond treating the immediate medical condition, and I feel less burned out and more invigorated and more connected to the work. I feel renewed. Spending time in nature is one way that I recharge outside of the emergency department. And the other day I came across these gorgeous flowers called fireweed. Fireweed got its name because in London after World War II bombings, it just flourished on the rooftops. It flourishes and thrives in the fire. Today, I want us to collectively envision a world where emergency medicine is like fireweed, not surviving in spite of fire, but because of the fire. When trauma-informed care is integrated into all of emergency medicine, the trauma that clinicians and patients carry will lead to meaning and renewal, and we can move from surviving to thriving.
I'm going to say the practical applications are what's so essential there. I mean, I think she really summed it up nicely. Instead of giving us something else to do, it's something that we can all do and it will be healing for us.
Yeah. It not only improves the patient experience, but it improves the experience for the provider because you're working together for the same outcome. And instead of framing patients as non-compliant or difficult, we're seeing them as an individual that needs support, and how do we, we have a framework to provide that support. When she mentioned a phrase in there that I want to point is universal precautions. In a medical setting, what does universal precautions refer to?
You do it in all situations.
Exactly. So because we've all experienced trauma on some level, and all of our patients have, and it's safe to say that every patient has some level of anxiety, implementing trauma-informed care as universal precautions is something that's going to put them at ease, which is going to help our experience as well. At the bottom there, and you'll see this when I send out the PDF of the slides, there's a link to the Future of Nursing 2020 to 2030. In chapter 11, it talks about health equity, and it really emphasizes trauma-informed care. So that's something that helps us to get buy-in from healthcare systems when they don't understand why this would be important. Also, the burnout that she talked about is an important thing that we definitely need to be supporting our frontline staff. The second link there is the key ingredients for successful trauma-informed care implementation. That's a wonderful document from the Center for Healthcare Solutions. And then at the bottom, Sharp Healthcare did a 5-module series on trauma-informed care. So you can learn more about trauma-informed care as well as get your continuing ed at the same time. Any other comments or things that stood out to you about the example that Dr. Stucklosa shared?
I just like the flower, the firebrand flower. That was really something beautiful to think about.
Yeah, in an adverse situation, that some beauty can come from that.
Mm-hmm.
Yeah, and I think that people that work in healthcare understand that, but when you're dealing with the daily stresses, it's not always apparent. Universal education is a big part of the instrument that I'm about to share. There is an instrument called the CUES intervention written by Elizabeth Miller. It's an evidence-based instrument that emphasizes safe relationships and human rights. It doesn't stigmatize patients. What's nice about it too is it addresses both the biases of patients and frontline providers, and it offers resources and support. And this is what's different from a screening tool is a yes, no, which can instead trigger defenses, but this approach is definitely more supportive to patients. So the CUES intervention, there is an adaptation of that called the PEARR tool, and it was developed by Heal Trafficking, the Pacific Survivor Center, and Common Spirit Health. So, and Common Spirit employs survivors in their healthcare system as well. And it stands for first provide privacy. We want to make sure that, because often the person that brings that individual in is the trafficker or part of that exploitation. We want to make sure that they have privacy so that they know they can talk and use their own voice. We want to educate them. That goes back to the universal education about safe relationships and how relationships affect our health. Also, it's important to educate them about their human rights, not just the foreign nationals, but even those who are Native-born Americans, because not everyone is aware of what their rights are, and it's important to address that. And then we ask them if we can help them with a situation. Sometimes if they're nervous, it helps to ask if they have a friend that could use help, because that takes the focus off of them. And then we respect whatever their response is. Not always is this person ready for a change, or we're not familiar with the types of coercion that are being used to keep them in that situation. And just like domestic violence, leaving is often the most dangerous time. So we don't want to force the issue. We just want to let them know that we can facilitate a change when they're ready. And then after we respect their response, we respond appropriately. So if they're ready for help, we can reach out to see what support is available to them. We don't want to overpromise. We also want to make sure that they're part of that process. We don't want to take control over it. We definitely want to make sure that their shared decision making is throughout this process. What's nice is once you've learned it, you can refer back to it as it comes up. At the bottom there's a link. The part of the SHARP Healthcare is trauma-informed care. One of the modules is on the PEARR tool that helps us to know how to use that so that patients feel supported instead of feeling manipulated. We definitely want them to feel comfortable, because if we alienate them, then they maybe don't feel safe coming back to receive the health care that they need. So I have a question that you can use the chat for this if you'd like, but I want to ask what the primary goal of a human trafficking or domestic violence assessment is. Is it 1, provide excellent care to all patients? Is it 2, give patients options? Is it 3, determine if it meets the criteria of mandated reporting? Is it 4, refer patients to social work and/or community support? The answer is number 1. It is critical that all healthcare providers recognize that disclosure is not the goal. Rather, the primary goal is to provide excellent care to all patients. The reason for this is that we don't want to create harm by alienating individuals from healthcare systems. We want them to know that if they're ready for help, we're there to support them. And if they're not, then they're welcome to come back and receive healthcare as needed. The others are also important to give patients options to determine if it does meet criteria for mandated reporting. This is a mandated reporting state. And we want to, when we do have a accidental injury or a minor being exploited where it is mandated reporting, we want to use all of the principles of trauma-informed care to make sure that that patient feels heard and seen, and that they're part of that decision-making process. And then the last one, of course, is refer patients to social work and community support. And it's important that we know what support is available before we make promises. Another aspect of this that is important, because often this is something that we're not, it's not on usually one person. It's important to create protocols for your department so that everyone knows what they should or should not do, so that social workers, nurses, doctors, everyone is working together to make sure the patient feels that their dignity and safety is being respected. Part of that's important is a non-fatal strangulation assessment. We want to make sure that we ask those questions appropriately, so that if they need additional imaging to make sure that they don't have any damage to their carotid, that gets addressed. This health subcommittee welcome packet, we're finishing the final edits on that, and we're going to be publishing that soon so that everybody can refer back to that to see what things that are included in these slides are also included in there, so that you can have resources to implement best practices. So I have a couple of case studies that we can talk out.
Okay, case study number 1. Shonda comes into the ER with severe stomach pain. A man identifies himself as Shonda's brother-in-law and offers to translate for her. He explains that although she has had stomach problems recently, she has not been to a doctor because she doesn't have insurance. Shonda does not make eye contact with ER staff or her brother-in-law. A nurse explains to Shonda's brother-in-law that she needs to examine each patient privately, and the brother-in-law says something harshly to Shonda in Hindi. Through the interpreter, Shonda informs the nurse she helps clean her brother-in-law's house and provide childcare. While she loves him and his children, Shonda is stressed because she works 12 hours every day. He supervises all of her phone calls and scrutinizes every phone bill. Hospital staff diagnose Shonda with a stomach ulcer and write her a prescription. Obviously troubled, Shonda says she's been to another ER before and had the same diagnosis. She stopped taking the medication because she's had trouble saving enough money to pay for the medication, and she is unable to go to the pharmacy without her brother-in-law's assistance.
Thank you. So there's some pros and cons in this scenario. One thing that I appreciate is that the providers used an appropriate interpreter, which is always necessary. We don't want to use family members or someone else. What are some of the red flags that you see here, and how can they be addressed with trauma-informed care?
I think one red flag for me is the brother-in-law sort of commanding the beginning of the appointment. And I think about the P and the PEARR tool providing privacy at first, getting Shonda alone and away from anybody else so that they can do an appropriate assessment, and she has a safe place to do so.
Thank you. Other comments?
Another red flag is the fact that her phone calls are supervised and the phone bill gets scrutinized.
Yeah. So how can we address that?
I'm not sure how, because he clearly has considerable power over her. The power differential is pretty big here.
Yeah. Well, and if we refer back to the PEARR tool, we can go back to the E for education. So we want to talk to Shonda about how relationships impact our health and educate her about her rights. So, anything else that y'all noticed in here that we can use trauma-informed care for? One thing that you can consider is if she's not ready for help, you can start like that safety planning process, and maybe do a follow-up visit, schedule her an appointment with a clinic or something so that she doesn't slip through the cracks, so that someone else can see her and continue to support her as she learns more about what her rights are and what she can do. Any other thoughts?
I think there's still going to be difficulty here because she can't get to a pharmacy without his assistance. Perhaps he provides transportation or something, but she's pretty much dependent on him to get anything, it looks like.
Right. Right. And that's where ask comes in with the PEARR tool. You know, we want to ask her if she's ready for help with this, if there's something you can do to assist after she's aware of what her rights are. And if she's ready for help, then you can respond with the appropriate supports. Other thoughts?
The bit about she loves him and his children made me think about the respect piece in the PEARR tool as well, because we don't want to discount that there is a relationship there that may be valuable to her, and other people, other family members that she loves involved. So just respecting that it's more complex than this guy is bad, this guy is good.
Exactly. And that goes back to the 6 principles of trauma-informed care, that cultural difference. We even see in some Asian cultures where there is like a debt bondage and they feel like it's dishonorable to break that commitment, even though they're obviously being exploited. And so we don't want to dismiss their culture. We just want them to be aware that they do have rights and that those unsafe relationships impact our health, and they don't have to stay in that situation. Now, if it's more serious than that, like a non-accidental injury that would warrant a suspicious injury report, or if there's obvious exploitation, especially of minors, we definitely need to report that. And even suspicion of exploitation of minors warrants a mandated reporting. But we want to make sure that we're working with the patient as much as possible to make sure that that's trauma informed. Thanks for that comment, Haley. I want to just summarize real quick that if we implement the human trafficking and domestic violence protocols and focus on best practice and trauma-informed care, that supports not only the patients, but the staff so that they don't have a moral injury. And we want to make sure that all of their policies and language are trauma-informed and use universal precautions. The PEARR tool will facilitate these types of conversations and lets patients know how relationships positively and negatively affect our